at two very interesting endocrine disorders, that is gigantism and acromegaly. These endocrine disorders are normally as a result of growth hormone disorder. So, but first things first, let us look at what the growth hormone is. So to review just the anatomy briefly, we know that the growth hormone is produced from the pituitary, and the pituitary is normally regarded as the master gland. So the location of the pituitary is normally around where the sella tussica is. This is just a kind of invagination that is around the sphenoid bone. So basically, this pituitary gland is divided into two, where we have the anterior pituitary and the posterior pituitary, and they are normally located just below the hypothalamus. So the hypothalamus plays a crucial role because it produces a hormone called growth hormone releasing hormone, which basically innervates the anterior pituitary to release or secrete the growth hormone. So when the growth hormone releasing hormone from the hypothalamus is released, it goes to the anterior pituitary, where actually it causes the secretion of growth hormone from the somatotroph cells in the anterior pituitary. So what does this growth hormone do? So basically, the name growth might actually be a bit misleading, but actually that is one of the main areas that the hormone works on. So the main function basically is to act on different body parts and ultimately helping in growth in children. However, that works in different ways. So we know that one doesn't remain a child forever, or basically the bones specifically close at the epiphyses. And when that occurs, therefore, the growth hormone does not stop functioning. Still, it functions by maintaining the normal bone cartilage and other organ structure by metabolism. So basically, it works together with other hormones, things like insulin, things like thyroid hormones, to actually facilitate metabolism and to maintain these body structures. However, the main function is to help in growth, especially in children. So how is it regulated? As many hormones do, we can either have regulation through negative feedback mechanism or positive feedback mechanism. However, so what triggers the secretion of growth hormone? So the first thing is if we have increased production of growth hormone releasing hormone from the hypothalamus, it will trigger the anterior pituitary to produce more growth hormone. As well, if you have low glucose levels in blood, growth hormone has a way of actually trying to increase this amount. So that will trigger more growth hormone to be produced so that it can actually help with the increase in glucose levels. Also, there's ghrelin, which is produced from the stomach, and this normally tells the body if there is hunger. So it will basically ask for you to eat. So basically, when ghrelin is produced, it also stimulates the pituitary to actually produce more growth hormone, so that ultimately we increase the amount of blood glucose as well. Also, exercise is known to basically result to more and more metabolism, and as a result, we end up using up the glucose we have, then we have depletion. Therefore, that will also trigger production or secretion of growth hormone as well. Trauma, whether physical or emotional trauma, is known to actually require a lot of metabolism as well, and that might actually cause or trigger the release of more growth hormone. However, there is an inhibition criteria for growth hormone. We have somatostatin, which is normally produced to counteract the action of most hormones, not just growth hormones. So somatostatin reduces the production of most hormones, including things like growth hormone itself. So apart from the action of somatostatin against the production of growth hormone, we also have, if we have increased levels of insulin-like growth factor 1, that leads to a negative feedback mechanism being sent back to the pituitary to produce less growth hormone, because insulin-like growth factor is a byproduct that is produced when growth hormone is taken to the liver. So we end up producing insulin-like growth factor. So therefore, an increase in insulin-like growth factor is an indication of high levels of growth hormone. Therefore, it will send a negative feedback mechanism. So as well, if we have low production of growth hormone releasing hormone, that will lead to less stimulation of the anterior pituitary to produce growth hormone, therefore reducing the amount. Okay, so now that we are clear with that, typically how does the growth hormone work? So it can either go and work directly. So we've already looked at its main function, but now if we break it down, it can either work directly by the growth hormone being produced, going and specifically to the organs that are required, especially for growth. That is especially the adipose tissues where lipolysis happens. It can go directly to the bones and cause the chondrocytes to actually help in bone elongation. And then it can also go to the muscles and help in uptake of amino acids and proteins, basically. So that can be a direct action of the growth hormone. But as well, it can actually go to the liver. Not it can, actually it goes to the liver. So normally it has both the direct action and the indirect action. So it goes to the liver, and the liver produces IGF, basically that is insulin-like growth factor. So insulin-like growth factor works exactly like the way the growth hormone works. The only difference is that it does not engage in lipolysis. But the rest of the other functions, like increasing the bone growth and also increasing uptake of amino acids or proteins, which leads to increase in muscle mass. Okay, so that is the only difference between insulin-like growth factor through the indirect action and the growth hormone direct action. So the growth hormone will do the rest of these other things, that is including lipolysis, that is breaking down these lipids from the adipose tissues or fat from the adipose tissues. It will also do increase in bone growth and also increase in muscle mass. However, it can also result in production of insulin-like growth factor, which only works on the bone and the muscle. So, and it doesn't cause lipolysis. So those are the two actions or pathways that growth hormone works. So if we are now to understand the disorders, we need to know, therefore, the pathways you've just talked about, that the growth hormone actually can go to the adipose tissues and it increases lipolysis, or basically the breakdown of fat. Also, it goes to the skeletal muscles, and what it does here is that it increases glucose uptake. That is therefore from the blood to the cells, increases amino acid uptake, and it also increases protein synthesis. Okay, that is what it tries to do. And then the other effect of growth hormone is that in the bones, more importantly, it causes chondrogenesis. Basically, we have buildup of the chondrogens, which help now in formation of cartilages and the elongation of bones. So you have increased glucose uptake still in the bone cells, increase in proteins through amino acid uptake, protein synthesis as well, and then increase the bone mass. The bone mass density is also increased, and also chondrogenesis. So this only happens up until puberty, because after puberty, the epiphyseal plates have closed, and therefore we cannot have elongation of the bones. So the other aspect is, we said it also acts on the liver. So it acts in the adipose tissue, skeletal muscles, and the bones. And as well as in the liver. So in the liver, it causes increase in gluconeogenesis, so that it increases blood glucose. Remember, we need this glucose so that it can enable it to be taken up by the different tissues, both the muscles and the bones. Also, glycogenolysis, basically formation of glucose from glycogen as well. And also, the insulin-like growth factor increases amino acid uptake, protein synthesis, and just like the way the growth hormone has been working. Okay, so that is how the growth hormone works. So now that we understand that, we can now delve into the two conditions, gigantism and acromegaly. We are covering them together because they are so much related. The only difference is basically the timing. So the gigantism is basically an abnormal high level of growth hormone, which is in excess. And that is the same case with acromegaly, basically an abnormal levels of growth hormone. Okay, now the only difference is that gigantism occurs in childhood. So the onset of increased levels or excess levels of growth hormone is before puberty. And what have we just seen that happens before puberty is the closure of just around puberty or afterwards, we have the closure of the epiphyseal plates. Okay, for acromegaly is still the increase in the growth hormone levels, and therefore it is the same concept. However, this happens after the growth plates cartilage fuses in adults, or basically the onset is after puberty, so later on. So this difference, especially on when exactly it occurs, leads to the differences that we see in the clinical picture. So what is the cause? Now, the cause is typically the same for both cases because the ultimate event is increase in growth hormone. So the number one cause, or the most common cause of increase in growth hormone, is pituitary adenoma. So these are benign tumor in the pituitary, which causes almost 95% of the cases. However, we can have other areas that lead to increase in growth hormone. So one, we can have a tumor in the hypothalamus that remember the hypothalamus produces growth hormone releasing hormone. Therefore, if we have like a tumor there, that will lead to increased levels of growth hormone releasing hormone being produced, and therefore increase growth hormone consequently. We can also have other areas like ectopic growth hormone releasing hormone. So basically, the growth hormone releasing hormone being released, but not from the hypothalamus. That is what we are calling ectopic. So basically from other areas, but not from the hypothalamus. So we can also have ectopic growth hormone itself being produced from other areas other than the pituitary. So pituitary is the anterior pituitary is the mainstay production area of growth hormone, but you can have extra pituitary areas, okay, like the pancreas is known to actually cause this kind of problem. Then we have other kind of neoplasias, like multiple endocrine neoplasia, which is called the main one. Basically, this is also known to cause an increase in. So basically, ultimate event in all these cases is that we have an increase in growth hormone levels. So the problem occurs now. Even if you look at it, we can basically see the event that the growth hormone will stimulate the liver to produce IGF-1, which can be divided into these three categories. The way that we end up having these excess levels, either primary growth hormone excess, which we have already talked about, or an increase in growth hormone releasing hormone, or we can either have an excessive production of IGF-1. So, but regardless, the ultimate event is that we have increased growth hormone and consequently increased insulin-like growth factor 1. So this is just the same concept you just talked about, where the primary growth hormone is produced in excess, or we can have it being produced from other extra pituitary areas, or we can have also the growth hormone releasing hormone being produced in excess. It can either happen at the hypothalamus, this one, or it can actually happen at extra pituitary, extra hypothalamus areas, basically, or ectopic. So therefore, what do we expect now from the fact that we know how the growth hormone functions? Therefore, what do we expect as the signs and symptoms? Now, for gigantism, we normally expect tall stature, basically, like this person over here, compared to this person. Actually, this person is tall, but as compared to a person who is has gigantism, they actually look like they are dwarf. So this occurs especially because the growth of the bone occurs much more early. The growth hormone is excess much more early before the growth, the close of the epiphyseal plate. So it gives a lot of time for the bone to elongate and grow and become big. And as the bone, especially the long bones grow, the height increases, and these people normally become very tall, as you can see. The other problem sometimes is macrocephaly, where basically you have a big head. Okay, but the mainstay kind of feature we expect to see in gigantism is especially tallness. So they're very tall. In acromegaly, remember this is happening past puberty, so the person's epiphyseal plate is closed. So tallness is not a major issue because the bones at this time have already closed. So you'll have other visceral organs becoming bigger and bigger because remember, we're having muscles taking up a lot of protein and glucose. We're having also still bones taking up all this. So people will still grow big, not necessarily tall, but big. So there's exaggerated growth of the hands and feet. So the hands look like they're thick or big, and the toes are also very huge. They have coarse facial features, as in the face looks very coarse, as in rough. And then they normally have what we call the frontal bossing. Frontal bossing, as you can see from the head here, there's a frontal bossing. And then there's a condition we call prognathism, basically where the jaw is very huge. And as you can see, it is almost like protruding. Then we have excessive sweating, hyperhidrosis, that they normally undergo that. And they might also suffer from osteoarthritis or obesity, which is very common in this case. However, there's some features that are common for both, things like soft tissue hypertrophy, other neuropathies, heart problems. These are common in both cases. One other thing that is normally a complication of this is becoming intolerant to glucose. So glucose tolerance, impaired glucose tolerance, and also diabetes becomes an issue. Remember, there is an effect on the blood glucose levels as well. So this is gigantism, as you can see. The main focus is on the tall stature. These are people compared to the normal height of other people. Acromegaly, as you say, the issue is not height, it is just the other organs. Now they look exaggerated. As you can see the face, you can see even in the trunk, you can see the hands, they look very big, and the feet. Okay, fingers are very huge as well. So diagnosis, therefore, remember, growth hormone is what is elevated. However, growth hormone itself is not a very good thing to measure in serum or in blood. So therefore, the element that is normally used very much is insulin-like growth factor. That is the one that is normally measured in serum. And if it is elevated, we therefore expect that therefore the patient has gigantism or acromegaly, depending on when it started. Also, oral glucose tolerance test. This is a test that is sometimes also used for insulin patients, for diabetic patients. So this is in the case where we have this condition, we have an inability to suppress the growth hormone levels. So during this test, okay, so this will be if we are not able to suppress the growth hormone by giving them the glucose, therefore that is a sign of growth hormone excesses. And then we have serum insulin-like growth factor binding protein. This is a protein that binds to insulin-like growth factor. Therefore, if it is elevated, that is an indication of elevated growth hormone. However, for lab tests, serum IGF-1 is the standard for testing for elevated growth hormone levels. Imaging can also be done. Remember, we said about adenoma, so CT scan or MRI can be done of the skull or of the head, so that they are able to check for this. Chest imaging as well can be done to actually check for ectopic, but this is rare. However, we can also check for tumors as well that are being secreted ectopically. So management is quite, so there's a lot of restriction basically. So once, for example, a kid's had gigantism and then they've gotten to a certain stage, if you have had an enlarged or tall stature, there's nothing you can do about what has already happened. What you might try to handle is now the continuous production of the growth hormone. So there are some medication that can be used to include dopamine agonists like bromocriptine, and that works by reducing basically the release. Then we have other growth hormone antagonists that block the effect of growth hormone itself. Then remember somatostatin, we talked about it being already something that counteracts growth hormone. Therefore, somatostatin analogs will help reduce the growth hormone release. But we also have other sex hormones like estrogen. These ones can also inhibit the growth of long bones as well. Apart from the drugs, radiation therapy is sometimes used, especially when we have cases of tumors. However, this does not normally have very good results. Surgery, especially the transsphenoidal surgery, is a common surgery for most pituitary tumors. So not just growth hormone problems, but just pituitary tumors are normally handled using transsphenoidal surgery. So thank you so much.